but we have to validate it, right? We're going to validate it. This is, we have nearly 160 publications already. But I would say that with just 2 publications that I'm gonna show you, you will be able to demonstrate that ENI is very useful. This was published in Anesthesiology in 2017 by a group of doctors in Germany. And what they are doing is basically very simple. They are just getting patients under propofol, and they are gonna submit those patients to an electrical stimulation. So it's a fixed stimulus, a current that will provoke a fixed nociception stimulation, right? And we are going to see the relationship of different parameters that they said that they are measuring nociception to the change and to that stimulation, okay? So we have this graph is what is called the ROC curve. A ROC curve represents how much is related one event to another. So the electrical stimulation to the change in the parameter. So we've got here different parameters. We've got the BIS monitor that we know is just hypnosis. We've got the heart rate and blood pressure in dotted orange and red dotted lines. Then you've got the green, which is SPI. Then you've got the red one is ENI, and the blue one is pupillometry. So we're going to make a tetanic stimulation with patients with propofol and intracutaneous stimulation, which is very similar to an incision with propofol as well. So when the curve goes much more on the left side, goes up, the area under the curve is much near to 1. It means that the relationship is very good. 1, it means that the relationship is perfect. It means that when I do this, I may say that, every time that something occurs, that other will occur as well. So the relation is perfect. And when you are here on the diagonal, the relationship is 50%, is 0.5. So you have the same chance of having the event than throwing a coin, okay? So the BIS monitor obviously is on 0.5 because BIS monitor is not looking at nociception, it's looking at hypnosis. So BIS monitor is not useful for detecting nociception. Heart rate and blood pressure is useful on 75% of the cases. There is 25% of the cases that is not useful when you're just under propofol. SPI, it's a little bit higher, nearly 0.8, 0.78. Then ENI 0.9998 and pupillometry 0.99, so very similar. And in the other way around, we are higher a little bit than pupillometry. So it seems that with propofol, pupillometry and ENI are the best ones to detect the noxious stimulation. But when we add remifentanil, which is very obvious during surgery, normally you will add opioids or analgesics, right? You see that pupillometry is very much affected. They have a sailing effect. The pupil cannot dilate itself anymore. But look what happens with heart rate and blood pressure. It goes to 0.5. Doctors are using heart rate and blood pressure to titrate nociception and analgesics when the relationship is just 50%. Do you imagine the doctors flipping a coin and saying, okay, it's face, I'm going to add more fentanyl. It's cross, I'm not going to add it. Well, this is what they are doing when they are managing their analgesia with heart rate and blood pressure, when they are using opioids. 0.5, no relationship. And the biggest relationship is due to ENI monitor, which is 0.9. Okay, 90% of the times we are going to detect the noxious stimulus. We will answer all the questions later on when we finalize the presentation. So we've got an index, or I would say a measure, that is directly related to noxious stimulation. We have seen that on the FUNK study. How are we going to use it? Well, we created this scale. Well, in fact, we didn't create it. What we did was just to observe which were the thresholds that we have to maintain. And in this case, in order to avoid the hemodynamic response, we said, and you have heard a lot of times, that we have to maintain our ENI values between 50 and 70. Which is the reason for this? Well, the first study that was done and published was just comparing ENI to hemodynamic response, because hemodynamic response was like the gold standard for nociception. So we realized that the relationship, and you see the rock curve here, that the relationship between ENI and hemodynamics is 75% of the cases. It's not all the time, it's not 100%, which is good. Because if we were just 100%, then they don't need ENI, obviously, right? Right? Because we do the same thing that hemodynamics. No, there is 25% of the cases in which we were not related to, so we don't know who, hemodynamics or ourselves, were better to detect nociception. Now we know, because in the Funk study we proved that, okay? We proved that we were better to hemodynamics. But here, that publication was 2017. This one is in 2010. So what we did here was to see which were the thresholds in which ENI will uh, correlate to the hemodynamic reaction. And we saw that when you go below 50, the increase of hemodynamic reactions appears. And when you arrive to 30, there is a 100% of probabilities that you will have an hemodynamic reactivity. And when we are in 82, you never had a hemodynamic reactivity. This was done with opioids, with sulfentanyl. So we can say that if you maintain your ENI on 50, 70, you will not have a hemodynamic reaction and you will avoid overdosing. Okay? If you go below 50, your probabilities of having an hemodynamic reaction increase until you arrive to 30, in which there will be a 100%. Okay, so if you are on 45, it doesn't mean that you will have an hemodynamic reaction. It means that the probabilities that you will have it are higher than if you are on 60. Okay, and if you go to 30, then you will have for sure an hemodynamic reaction. And in this publication, we saw as well that the hemodynamic reaction occurs nearly 5 to 10 minutes after the ENI falls. So you can prevent the hemodynamic reactivity. Okay. So this is the reason why of that threshold, 50, 70. But I want to tell you as well that in a sleep patient, imagine that you're sleeping comfortable this night. Your ENI value will be 100. Your parasympathetic activity will be very high. Okay. It doesn't mean that you're overdosing, right? It means that your parasympathetic is very high. And that's not bad. It is bad if I am just giving opioids and I'm putting you on 100 just with opioids. Then you can have side effects because the amount of opioids that I have to give you to leave you to that point when you are under surgery is that much that you will have nausea and vomit, etc. All the side effects. Okay, but if you are just sleeping, you can go to 100 very easily, and there is not overdosing of everything. Okay, of anything. Another point, if you're under an epidural and you are asleep, the epidural will block completely all the afferences. So it's very likely that your ENI values will go over 80 and 90. And that is not overdosing. It means that your sympathetic is very good under control. Okay? And when you go with multimodal, which means I'm mixing different kinds of analgesics, like opioid-free anesthesia, for instance, I'm adding dexmedetomidine, lidocaine, ketamine, sulfate magnesium, etc. Then it's very likely as well that I will have an ENI of 100. And I'm not going to have side effects because I'm adding just a little bit of every drug, which is provoking a very big block. And those very little things are not provoking side effects because it's very small amount, but will provoke all combined a big sympathetic block. And this is why it's very good. Okay, I hope you understand this. If not, I will clarify later on the answer and question and answers. So we go for the next part. The next part is Annie in the OR. As I told you, we have two values. We have the ENI value, which will help us to titrate and guide our analgesics. And we've got the energy value that will tell me what is happening with my autonomous nervous system and how powerful my autonomous nervous system is. And this is important, no? One of the main things that we have to understand is that we are not treating pain while I'm during general anesthesia. As I told you before, if I am unconscious, I cannot feel pain. But what do I have? I have the reflex of my autonomous nervous system. And the reflex of the autonomous nervous system means the sympathetic activation and means the inflammation process activated. And that inflammation process is the one that is going to provoke that acute postoperative pain, the chronification of that pain later on, and as well in frail patients, we can talk about cancer and we can talk about cognitive dysfunction and other problems, infections, etc. This was said by Dr. Gray already in 1962. Probably you have heard about the triad of anesthesia, right? Hypnosis or narcosis, as he said, analgesia, and neuromuscular blockade agent. Those three arms, it's anesthesia. That was done by Dr. Gray in 1952. But 10 years later, he said he was wrong. He said analgesia doesn't exist during general anesthesia because a patient cannot perceive pain, and analgesia means no pain. Pain doesn't exist while I'm narcotized or while I'm doing hypnosis. Cannot exist because my cortex is not perceiving that thing. There is something, yes, of course. The body is reacting to that. There is a reflex of the autonomous nervous system with all that inflammation release that we talk about. But that is not pain. This is another thing, okay? That is called surgical stress. That is the devil that we have to put in the jail. And in order to do so, we have to measure the autonomous nervous system, okay? So why do anesthesiologists provide painkillers? Painkillers. Well, in fact, they provide painkillers because what they want to do is to promote the parasympathetic activity in order to have under control the sympathetic inflammation reaction, okay? And to keep that balance that I showed you at the beginning. It's already proven that if you use ENI during your general anesthesia, you will be able to titrate your analgesics, not only your opioids. ENI can be used during opioid-free anesthesia, can be used with blocks, can be used in any circumstance. And when you titrate your analgesics, then you will be able to improve the outcomes of your patients because you will know and that detect the etiology of the hemodynamic event. So you will know if that hemodynamic event has to be treated with analgesics or not. And you will be able to predict the postoperative pain. And you will be able to diagnose, the hemodynamic reactivity. You will be able to detect it in advance, as we said. So we are going to be able to predict hemodynamic reactivity. This has been proven by several articles. There is one from Boselli, but this one is from Mathieu Jean, is one of the first ones that was published. And it says that if you are, what I told you, with a ENI value lower than 49, then the probabilities of having an hemodynamic response increase very much until you arrive to 30. And it will happen in the next 5 minutes. So you have 5 minutes to react and to add the right drug in order to avoid to have that hemodynamic reaction. One of the examples that I normally do is if you have two anesthesiologists in the OR and one is looking at the ENI and the other one is looking at the hemodynamic screen, you will see that the one looking at the ENI is doing things, is administering this drug, is decreasing the etc., while in the hemodynamic monitor, everything will be very stable. The other one will not be doing anything. And you know what happened? A lot of times I've been in the OR and the doctors, when the ENI reacts and the hemodynamic monitor doesn't, they said, well, but if I treat that reaction of the ENI monitor, I'm treating the monitor, I'm not treating the patient, which is laughing. What happens is that they trust much more on the hemodynamic monitor than the ENI. Why? Because they have been doing anesthesia with the hemodynamic monitor for ages, while the ENI is the first time that they have it in there, right? But the ENI is much more precise and much more sensitivity, as we saw in the Funke study, and it's faster, as we can see here. So we will be able to prevent those hemodynamic responses much better if we follow ENI and not hemodynamic. Hemodynamic monitors should be a forget in order to titrate analgesia because the relationship with nociception is just flipping a coin. And you see it here, okay? But we have to convince them. This is the change of paradigm that I told you. People has to put their fingers in the wound, okay? They have to see it. So this other study is proving as well that we are able to diagnose the etiology of the hemodynamic event. Doctors, when they are in the OR and they see that they have an increase in blood pressure, they don't know if they have to increase, well, before the abuse monitor of the set line, they didn't even know that if they have to increase the propofol or the sevoflurane. Now they know it. So now the question is, should I increase my analgesia or should I put a vasodilatator? And normally, you know how they solve it. They just give an extra bolus of fentanyl, and if it's solved, it's fine. And if not, they said, well, I was wrong. I will go for nicardipine or urapidil. But the patient had already an extra dosage of fentanyl, right? So this study was done in order to prove that ENI is able to detect that. So what we did was an observational study, and we said, well, the protocol is going to be the following. If the ENI, if the hemodynamics increase at 20%, then you will give a bolus of analgesic, of fentanyl. And if the blood pressure goes down, then obviously the reason why it went up, it was because of nociception. And if it doesn't, if it stays high, the blood pressure, obviously I have to add a vasodilatator because the etiology, the cause why the blood pressure was high was not nociception, was hemodynamics. So they did that, and they observed what happened with the ENI. And they realized that with a high blood pressure, when those patients were reacting to the sulfentanyl bolus, decreasing the blood pressure, the ENI was already low and was telling to the doctor that, yes, you have to add some sulfentanyl. And probably it was lower 5 minutes before. So we could have already add that sulfentanyl before that hemodynamic reaction. And those 5 minutes, the patient was already releasing inflammation, which is the reason why it caused pain later on. There were other patients in which the blood pressure was high and didn't respond to sulfentanyl, so they had to add nicardipine. Those patients already had high ENI, telling you have a high parasympathetic, so telling you are not in pain. You have to go other way. You have to go to nicardipine. So ENI is able to differentiate when you have to add fentanyl or when you have to add urapidil. Okay, if you have a high ENI and a high blood pressure, go for urapidil. Don't go for fentanyl. And this is the case that I'm going to show you here in YouTube. Let me see. I'm going to put you another video. This is a patient in which you have 150. Oh, sorry. One moment. The other video start. I'm going to go for the right one. So you can see here a patient with a high blood pressure, 150, 96, with a high ENI, 78. You can see the energy is 0.2. Sulfentanyl, 0.24 nanograms milliliter. So high ENI, high blood pressure. We don't need to increase the sulfentanyl. The doctor is just adding nicardipine, 1 milligram of nicardipine, and you will see that the blood pressure is going to decrease by itself while the ENI stays high, and we don't treat it with sulfentanyl. We don't increase the amount of sulfentanyl. So we don't overdose the patient. In this case, we treat it correctly, and the patient will maintain his homeostasis and his balance. You see, this is the cardiac, and then the blood pressure decreased to 96. Okay? Okay. So we can titrate analgesics. Yes. As you can see in this paper, and I put this one because there are other ones. There is a very recent publication from Pedro Amorin as well, which is showing exactly the same thing. In this case, I put this one because it was done in children. So ENI can be used in children as well, in pediatrics, and it's very useful for sure. So what we are doing here is as well a tetanic stimulation, so a noxious stimulation with different levels of remifentanil, decreasing levels of remifentanil. So we have no stimulation, so we have a high ENI, right? A high ENI. And if we have an stimulation, then the ENI will decrease. Obviously, it will decrease as long as the nociception will be stronger or higher. So if we have lower remifentanil concentrations, the response will be higher. And this is what we can see here. We have a high ENI with a certain amount of remifentanil, and it decreased when we put the noxious stimulation. It decreased again, and it's increasing the difference between the previous and the post stimulation as long as we decrease the remifentanil concentration. So we are able to see and to detect the different levels of remifentanil that we are having in the patient, because the response of the ENI is bigger as long as we decrease the concentrations of remifentanil. Which, by the way, this study is comparing it as well with skin conductance, and you can see that the skin conductance is not able to detect the noxious stimulation until you really have a very low dosage of remifentanil. So we are much more sensitive than skin conductance to detect the stimulation. Another point that you have to understand is that drugs takes time to make effect. That's why you have a watch in the screen of the monitor. So when the doctor add a bolus of fentanyl, look at the watch and see which time is it, because in 5 minutes and not before, you will have the response of the fentanyl, because fentanyl takes nearly 5 minutes to respond. This is the case, okay? We can predict post-op pain. Obviously, this is a publication from Boselli in BGA, a very important magazine, in which he proved that when everything is finished, but the patient is still asleep, you got already analgesia, you let the ENI make a stable. The value of ENI will reflect which is the balance between the sympathetic and parasympathetic of that patient after all the stress that he has had. And if that balance is over 50, it means that the patient is already on the parasympathetic side. So there is not that much nociception on the patient. So the patient, when he will awake, he will have a value of NRS score, which is a value of pain, 3 or below 3. It's you know that NRS is a scale that goes from 0 to 10, and 3, it's no pain, 3 to 5, moderate pain, from 5 to 7 is severe pain, and 7 is extreme pain, okay? So no pain if your ENI value is below 50 before awake. You have to have as well into your mind which kind of analgesia you give. If you just give remifentanil, that moment or that circumstance will just last 7 minutes. If you add fentanyl, you will have nearly half an hour without pain. If you got morphine, you will have 6 hours without pain, okay? So thanks to that, we are going to be able to improve the outcomes. And that was proven. And this is the second article that I told you. So if you have to have in mind Funke and Upton study. With those two studies, you really will solve any problem. This one was published as well in 2017 in Anesthesia and Analgesia, and was spinal surgery with sevoflurane and fentanyl. What they did was very simple. One group guided with ENI, trying to maintain it between 50 and 70, and the other group just guided by hemodynamics. And they look at the NRS scores afterwards, post-operatively. They realized that the group guided by ENI had scores of 3, as you can see here. 3, 4, so no pain. So this was the reason why the amount of fentanyl given postoperatively was very low. While the other group, the hemodynamic group, had values from 5 to 7, so near to moderate severe pain that has to be treated immediately with fentanyl, that you can see in the other graph, right? So they show, due to this amount of postoperative fentanyl, they were having more nausea and vomit, they were having more shivering, 23% more shivering, 28% more antiemetic drugs, 4% more naloxone use, 1.8 less pain, 30% more opioid consumption. So that means money, because it's more time on the reanimation. And as well, the most important thing was that when they look at the amount of fentanyl given intraoperatively, it was the same amount. So, which is the reason why if I gave the same amount of fentanyl in the two groups, I get that very different outcomes? Well, they look at how the fentanyl was administered, and they show that in the ANI group, the majority of the amount was given in the first 45 minutes, and it was given in smaller boluses of 25-50 micrograms, while in the other group was given boluses of 100 to 125 every half an hour. In the ANI group, you can see in the graphs here in colors, the ANI group was able to maintain the ANI values in higher values than in the other group. The authors conclude that they were able to detect the noxious stimulus much better than with hemodynamics, as Funke already proved, right? Funke proved that only 50% of the noxious stimulus were detected with hemodynamics, and here 90-95%. So that's the reason why we were able to detect the noxious stimulus and treat it immediately, avoiding the neuroinflammation, the neuromodulation. So what we were talking before, the sympathetic response, the activation of the inflammation, which is linked, as we saw before as well, to postoperative pain, to chronification of pain, and to other problems like we talked before. Okay. So this is a very interesting video that I'm going to show you, because you will see that when you do a demo. This is a low ENI value, 40, with a good energy, 0.3 in a patient that is under anesthesia, but very low blood pressure, 80/46 with a media of 58. We should maintain the blood pressure over 65. With a Vis value of 47, so the patient is well asleep. 1.5 sevoflurane is not an awareness. An awareness could provoke low anis. With an effect site concentration of 4, remifentanil 4, it's a lot. So here it's very difficult to convince the doctor that his ENI value should improve, should increase, giving more remifentanil, but this is in fact what is happening. How would you convince him? Well, I will show him the Funke study, which telling them that the hemodynamics only are linked to nociception in a 50% of the cases, while ENI is linked in 90% of the patients. And I will show Upton study, because it will tell them, if you follow the ENI advices, not the hemodynamic advices, you will get a 3 in NRS scores instead of 5 of NRS scores, and you will use 30% less fentanyl postoperatively, you will not have nausea and vomit, etc. So this is what we did. We just add, because he didn't want to increase remifentanil, but we add some lidocaine. Lidocaine takes nearly 10 minutes to make effect. So we put the lido, you see the lido signal there. We maintain the remifentanil concentration. We didn't do anything. We didn't change anything. Just add lidocaine in a slow boluses, 44 as a Vis monitor, so stable. Even the blood pressure increased a little bit, because nociception can provoke as well hypotension. Low heart rate, the sevoflurane was maintained. And here you see the lidocaine going into the vein of the patient, 100 milligrams. And you can see now the ENI raising, improving the surgical stress of the patient. We had to add some analgesics. So in this case, we add lidocaine, but if you have a patient which is with low blood pressure, maybe ketamine could be a good option, okay? But there could be any other indications. So we have seen what we have talked. We have seen the ENI guiding analgesics, but we talk about as well energy value, right? And the energy value is what I told you. It's telling me how much money I have in the bank, in the autonomous nervous system bank, how much big is the cake, okay? And already in an editorial in 1999, they were saying that wouldn't be important for our specialty, so for anesthesia specialty, to keep control of the autonomous nervous system. And they were saying that there are some data suggesting that low heart rate variability, so low amount of money in my bank, is an index of impaired cardiac vagal tone, an independent predictor of mortality after non-cardiac surgery. So energy value can be used in order to assess preoperatively the patients, in order to detect the frailty of those patients. These studies has to be done, but it's something that we can propose to our doctors to in the anesthesia office before going to surgery, to assess at the same time, preferably early in the morning, 8 9 a.m., which is the amount of energy that my patient has and the ANI. And if the energy is very low, to see and compare it maybe with SOFA or other scores of frailty, and to see the outcomes later on, because there is a lot of publications relating total power, so energy, and HF-nu to mortality in the patients. This other study, for instance, is talking about that the energy value, it's an indication of the physiological reserves of the patients undergoing major abdominal surgery. So we have like two important messages. One, the one which is proven, mainly, well, supported by 150 publications, but I would recommend just to keep in mind Funke and Upton study, okay, which is very good. And then this other approximation, this other hypothesis that needs to be developed, saying energy value, it's a very important value that if it's very low, it's an indicator of frailty. And there are already publications as well, not only of about surgical reserves and mortality, etc., but if the patient has a very low energy during the operation, that may be an indicator of hypotension.